Hello, my name's Professor Roger Whittaker. I want to tell you today about some work we've been doing on a new technique that we've been developing for about 10 years now called motor unit MRI. And this is focused on improving the diagnosis of motor neuron disease. So when we talk about motor neurons, it's worth just reminding ourselves what they do and where we find them in the body. So motor neuron disease affects both what we call upper and lower motor neurons. So in the diagram on the right, you can see a schematic of the brain and the spinal cord. The motor neurons within these parts of the body we refer to as upper motor neurons, and then coming from the spinal cord out in the limbs and down to the muscles, we have the lower motor neurons. And it's the lower motor neurons that I'm going to focus on, particularly in this talk, not least because these are the tissues that give us the most useful information for diagnosing the condition. So on the left of the slide, you can see an expanded view of part of the spinal cord. And although any muscle will have several hundred motor units, I've just highlighted 3. So the motor unit is a single motor nerve cell, which we've color coded here, orange, blue, and yellow, in the spinal cord, which then sends out a projection called the axon, and then this axon divides to supply, depending on the size of the muscle, several hundred muscle fibers. So the individual motor nerve and all of the muscle fibers that it supplies is one motor unit. And critically, when that motor nerve fires, all of those muscle fibers that it supplies will contract roughly at the same time. The second thing to point out is, as you can see from the diagram, is the muscle fibers that each of those motor nerves supplies are interdigitated. By that I mean that the fibers from one motor unit overlap and crisscross the fibers from another. So what is it that the motor units do? Well, any movement that you make is ultimately made by the activation and contraction of motor units. And depending on the movement that you make, you will activate different populations of motor units and different numbers of motor units. So for a very fine movement, you might activate just a few motor units, but for a very powerful movement like picking up a heavy weight, you would activate far more motor units. And the fundamental pathology in motor neuron disease is that we lose both upper motor neurons and lower motor neurons, and consequently we end up losing motor units. So this causes a number of symptoms and signs, but ultimately it leads to weakness of the muscle. It leads to wasting of the muscle, so a reduced volume of muscle. And in the early stages, it can also produce spontaneous contraction of the motor units. And sometimes you can see that at the surface as a small flickering in the skin that we call fasciculation. And we're going to hear much more about that later on in the talk. So at the moment, how do we diagnose patients with motor neuron disease? So largely that relies on what we call neurophysiological tests. So in my day job, I see patients in my clinics, and amongst them patients who are suspected of having motor neuron disease. And essentially there are 2 broad types of tests that we can use. On the left, we have what are called nerve conduction studies, and this involves giving small electric pulses to the nerves to activate motor units that we then record with electrodes that you can see placed here on the thumb. And on the right, the second technique we use is called electromyography. So this involves placing a small metal needle within the muscles and recording the electrical activity. As you can imagine, this is not very comfortable. For a disease like motor neuron disease, we would probably look at somewhere between 6 and 10 muscles. Each of those muscles takes a few minutes to study. We're moving the needle around within the muscle whilst we do that. So it's quite uncomfortable. But more importantly, we're only recording from the very tip of that metal needle. So in any given position, we're recording from probably about 1 cubic millimeter of muscle. And the problem there is, if we happen to hit a piece of muscle that hasn't been affected by the disease, we might miss the diagnosis. And not infrequently, even having studied up to 10 muscles in a patient, we're not certain of the diagnosis. And sometimes we have to bring them back after 4 to 6 months to repeat the whole process. So the current tests are not ideal. And a lot of our focus is on trying to develop better ways to make the diagnosis. But before we move on, just thinking a little bit more about what we're looking for in the neurophysiological testing, there are 2 features that we need to see. One of them is the loss of motor units, and that, as I say, can manifest as spontaneous contraction of the motor units, which we see as fasciculation. And secondly, we need to see remodeling of motor units. And that's a sign of what we call reinnervation. And on the EMG, the electromyography, that shows up as increased complexity of the signal that we record. But critically, in any given muscle, you need to demonstrate both of these features in order to meet the diagnostic criteria. So why does it matter if we need to bring a patient back 4 to 6 months later to get the diagnosis? Well, this all leads to diagnostic delay. And if we think back 50 years, in 1975, it took about 12 months from a patient first noticing a symptom, that might be twitching in their muscles or a little bit of clumsiness in one of their limbs. It took 12 months before typically they would be finally given a diagnosis of motor neuron disease. Moving forwards 50 years and 50 years of intense research into improving the diagnosis of motor neuron disease. And in 2025, it takes about 12 months from a patient first noticing symptoms to them getting diagnosed with MND. Absolutely no change whatsoever in 50 years. Why does this matter? Well, understandably, this causes huge distress for the patient and their family. They know that something is wrong, but nobody can tell them what the problem is. It delays access to life-prolonging therapies. It delays recruitment to clinical trials. So there is huge efforts being put into developing new treatments for motor neuron disease. The point is that if you have waited 12 months from your first symptom to even being considered to enter one of these clinical trials, in that time, you have probably lost anything up to half of your lower motor neurons and half of your motor units. So that is a very big ask for any new treatment to overcome. If you've already lost half of your motor units, it's extremely unlikely that there's ever a treatment that will fully recover that function. So it's critical that we get patients recruited into clinical trials as soon as possible before they've lost that 50% of their motor units, because that's the only way that a new treatment can have a chance of working. The fourth problem with delayed diagnosis is that in that 12 months, when the patient knows that something is wrong, but nobody can tell them what the diagnosis is, they have countless unnecessary clinic visits to all sorts of clinical specialists. People are referred to see orthopedic surgeons, they are sent to see rheumatologists, elderly care physicians, all manner of specialists who are not the right people for these people to see. They should be seen by a neurologist, because ultimately it's the neurologist who will make the diagnosis, follow up the patient, and instigate any treatment that is available. So seeing these other specialists just is a wasted clinic visit. And worse than that, those specialists will usually order some tests because they're doing their best to figure out what's wrong. So patients get lumbar punctures, they get blood tests, they get ultrasounds. And when you look back, the vast majority of them will also have had an MRI scan at some point. So this is a sort of a merry-go-round of unnecessary clinic visits, unnecessary tests, and even sometimes unnecessary treatments in that 12 months, trying to figure out what the diagnosis is. So just to reiterate that point, in that 12 months, between 80 and 90% of patients who are eventually diagnosed with motor neuron disease have already had at least one MRI scan by then. Okay, so let's think a bit more about MRI scanning. So we've been working on this new technique for about 10 years now, and we were not the first to notice that when patients were having MRI scans of their muscles, occasionally you would see these regions where the image just disappeared. So what you're seeing here is an MRI scan taken about 8 centimeters below the knee. So the black areas at the top of the image, that's the bone, and then the gray areas are the muscles in the leg. And there's 3 images here taken 1 second apart. And in the middle image, I've circled a region where the gray muscle just goes black, and then a second later, it's disappeared again. And the radiologists who were taking these images were thinking, how do we get rid of these irritating artifacts that are spoiling our images? So when we saw these as neurophysiologists, we thought, well, hang on a minute. These are transient events that only ever happen in the muscle. They're about 10 millimeters in diameter, and we happen to know that's the size of a motor unit. So we wondered whether actually these represent the contraction of a single motor unit. So that was the hypothesis. And in order to answer that question, we used electrical stimulation of those motor nerve axons so that we could control precisely the activity of the motor units. So by giving electrical stimulation of different intensities, we can either activate 1, 2, 3, or several hundred motor units, depending on the stimulus that we deliver. And what does this look like in our experimental setup? Well, it's pretty complicated. So in the middle image, you can see we have an MRI scanner. This is in our research center in Newcastle University. The MRI scanner is actually completely standard. It's identical to an MRI scanner that you would find in a hospital. But we've tweaked it so that when the MRI scanner takes an image, we can take the timing pulse that the scanner generates at that time, and then we can use that to control a nerve stimulator, which we then feed back into the scanner via wires that you can see attached to the side of the subject's leg. So every time the scanner takes an image, we can deliver time-locked electrical stimulation at any time we like and at any strength we like. And that means that we can precisely control when those motor units are activated. And to cut a very long story short, with various experiments, we were able to show that those black blobs that appear in the image are indeed the contraction of single motor units. Now, you remember earlier on I mentioned fasciculation, and that is the spontaneous contraction of a motor unit. You can sometimes see it at the surface as a little twitch in the skin, but often you can't see it because it's happening deep down within the muscle. It's a sign that the motor unit is sick, but critically, it is still alive. So there's a huge amount of interest in detecting fasciculation because it's an early sign of motor neuron disease, which happens before you've lost the motor unit. So it means that it's potentially salvageable. So again, just to reiterate, if you want to recruit patients early and get them into clinical trials early, then fasciculation is a good candidate to look for to diagnose those patients early on. So a number of years ago, we did a small study where we recruited some patients who were known to have motor neuron disease, also known as ALS, which is what the label says on the figure. And we didn't actually use any of the complicated setup that I've shown you on the previous slide. We literally asked the patients to lie in the scanner as relaxed as they could, and we took images of their muscles. We didn't use any electrical stimulation, nothing else, just literally having the patient lying in the scanner. And the images on the left are, again, just a video of lots and lots of images taken 1 second apart. And on the left, you can see the patients, and on the right, you can see healthy controls who do not have motor neuron disease. And even on the right, if you look very carefully, occasionally you'll see little black blobs appearing in the muscle because everybody does fasciculate. You'll have noticed this after heavy exercise. You sometimes notice that your thigh muscles are just flickering a little bit. That is fasciculation, and it's completely normal. But on the left is the patient, and you can see very easily there's a lot of these signal voids. Now, they're quite deep in the muscles, and that's why you can't see them at the surface. But we were able to show there was well more than 10 times as many fasciculation events in the patients as there were in the patients, in the healthy controls, excuse me. So this ticks the box, if you like, for that first part of the criteria. This gives evidence of de-innovation. And we don't just do this in the legs. We've subsequently developed what we call a whole body imaging protocol, where we can look at the arms, we can look at the back muscles called the paraspinal muscles. We also look at the legs, but then on the far right, we also look in the tongue. And you can see in different patients, we've just sort of drawn the number of fasciculation events as a heat map. In some patients, most of that is in the back muscles. In some patients, it's in the legs, and in some, it's particularly in the tongue. So we've taken this and we're now applying this in 6 centres around the UK. And this is a different project called the Final Sum Project, where we're asking patients to come in who are suspected of having motor neuron disease, and they're being scanned on completely standard NHS scanners. So this is an example taken from our colleagues in Leeds who've scanned this patient. I don't know anything about this patient because at the moment this is all still fully anonymized, but you can see that along the bottom axis, you can see these are similar images of their tongue on the left, the shoulder, the back muscles, and the leg, and you can see lots and lots of these fasciculation events. Okay, so we've made quite good progress on the fasciculation scanning and the de-innovation part of the criteria. But if you remember back to what I said earlier, we also need to show re-innovation. And that really comes down to the number of motor units that are left in the muscle. So we need to find a way of using the MR image to also tell us about re-innovation. And that's the work that's been funded by MND Scotland and that we're currently working on in a 3-year grant. So each of the motor units within a region of the muscle contributes to the blackness, contributes to the signal. And just to remind you, again, just look on the left, those motor units overlap. So in any one region of the muscle, you typically will have anything up to about 10 motor units overlapping, each potentially contributing to the degree of blackness. And we've used that fact by saying, well, let's just think of the simple case when we have 3 motor units, all overlapping, all within a certain region of the image. If we give them each a value saying when they're on, they contribute a 1, and when they're off, they contribute 0, there are 8 different combinations of firing patterns of those 3 motor units. So in the top left, they could all be off, 0, 0, 0. In the bottom right, they could all be on, 1, 1, 1, and then anything in between. And overall, there are 8 different combinations of how those 3 motor units could fire. With 2 motor units, there are 4 combinations, and with 1 motor unit, it's either on or it's off. So there's 2 combinations. So each motor unit contributes to the signal that we record in our memory images, and the number of different signal intensities that we detect tells us how many units are present. So if we see lots of different signal intensities within a region of muscle, we know we have lots of different motor units there. If we see very few, and in the extreme case, we might just see on or off, then we have very few motor units there. So what does this look like in our images? So this is going back to the electrical stimulation, and we've 2 lines here. We've got a red line, which is what happens to the signal intensity as we change the intensity of our electrical stimulation. And you can see it's a very smooth change, and that is in a healthy subject with lots of motor units, whereas the blue line is in a patient with motor neuron disease who has very few motor units, and you can see that we don't see this smooth S-shaped curve. We see a much more jagged, stepwise change in signal intensity. And this tells us there are fewer motor units within that region. So that's all very good. And we have to use our very, very complicated setup with the MRI scanner and the wires and the electrical stimulation and our very complicated system. The problem is there's no way you could use this within the NHS because it needs a lot of expertise to use our research grade stimulation kit. If you introduce anything extra to the MRI scanner in the clinic, it breaks the CE marking. So the regulatory approval for that scanner disappears. And also just having wires and extra pieces of equipment in a busy NHS scanner is just not feasible. So although we can show using electrical stimulation when a patient has fewer motor units, this is never going to fly as a clinical tool to be used in the NHS. So the question we had to find an answer to was, how can we produce similar information in terms of the number of motor units without using any extra kit? How can we do this on a completely standard scanner? Remember, that's what we've done for the fasciculation scanning. We don't use any extra kit. It's a completely standard scanner. How do we get that same information, but also tell us the number of motor units? And let's just get our wish list then of what we need to be able to do. Number 1, we've got to do it on a standard scanner with no extra kit so that we don't break the CE marking. We do need the activity of the motor units to be time locked to the scanner so that we can image them, so we know when they're going to happen and we can know when to take our images. We have to consistently activate a defined group of motor units so that we can count how many are active. And finally, we need to show differences between healthy subjects and patients with motor neuron disease. So The approach we came up with is this: auditory paced movements. So, but humans are extremely good at making time-locked movements to noise. And this is what it looks like within the MRI scanner. So here we have a healthy subject lying in the scanner. And unfortunately, because it's an MRI scanner, we can't take a camera in there. So this isn't a great picture, but you're looking at a picture that we've taken of the screen that is looking into the bore of the scanner. So the subject is lying on their back. You can just see their feet here, and these are their arms. And what we're asking them to do is tap their foot and tap their hand in time with a beep that's played over the headphones of the scanner. Okay, so that's all we're asking them to do. I'll just play that again. So without any extra training, we've just asked this person to tap their hand and tap their foot in time with an auditory cue. And on the right here is a comparison between what we see when we use electrical stimulation to activate the motor units and what we see when we use this auditory paced activity. So the top of the graph, this smooth curve here, is the contraction of the muscle as we follow it with a force transducer within the scanner. The blue line underneath is what we see when we use electrical stimulation to activate the motor units that are producing that force. And the orange line is what we see when we use the auditory paced. And you can see that although they're not entirely identical, with both the electrical and the auditory paced activity, we see one initial large curve and then a second later curve. So this gave us hope that we were at least onto something credible in terms of being able to replicate the electrical stimulation. So the next question is, well, how accurate are untrained subjects? So this is, again, someone making auditory paced movements. They're tapping their foot against a force transducer inside the scanner. And this black trace here is the resulting force. What you can see down here are in orange, are the beeps that they're being asked to tap in time with. And then the blue lines are when we've taken the image. And you can see the black line here, which is the actual movement, is extremely consistent. And if you do this for several minutes within the scanner, we get an accuracy of plus or minus 1 to 2%. So the timing when the person makes that movement varies only by plus or minus 1 or 2%. And that's extremely accurate and is easily accurate enough for us to be confident that we'll be activating the same population of motor units. So what does this activity look like? So you're getting familiar with these images now. This is, again, back to the leg. The black region here is the bone, and then this region here are the muscles that we're activating when the subject taps their foot. So you can see that we get these regions of signal dropout, and each of these is the contraction of a motor unit. Remember back to our earlier slide where the number of motor units that are present tells us how many different possible signal levels we can have. And what you can see here on the right is that in that region where we have the motor unit activity, we get a very different number of possible signal levels to the rest of the muscles which are not being activated. So this gives us a way of quantifying the number of motor units that are contributing to this activity. The second question is, well, how consistent is the activation? If you remember, we need to be able to activate the same population of motor units. So here we've got two subjects. So along the top line is the first subject, and they're doing exactly the same experiment. in the top left, and then we wait a few minutes, and then we repeat the experiment in the middle, and then we wait a few minutes, and then we repeat the experiment on the right. And again, you can see there is a very consistent pattern and region of activation that we see in the muscles that are being activated by that movement. Beneath that is a second subject doing the same experiment, and you can see it's a different pattern of muscle activity, but again, across the 3 experiments, it's extremely consistent. And finally, can we control which motor units we activate? Well, if you remember, we're giving an auditory cue, and we can control when we give that cue, either exactly in time with the imaging, or before the imaging, or slightly after the imaging. And again, we've done that in the same subject. We've changed the timing, and you can see that in the top series, we're activating a population of motor units up at the top of the leg here. And then when we change that latency, we're activating a very different population of motor units. Remember, this is not using electrical stimulation. This is just getting the subject to tap their foot in time with the beep. So to summarize, where are we now? Let's go back to our wish list. Can we do this on a standard scanner with no extra kit? Yes, we can. All we're using is the standard scanner and the headphones that come with the scanner, nothing else. Is it time locked to the scanner? Yes, it is, because we're seeing activation that is only present when we are imaging at the time of the muscle activity. Are we activating a defined group of motor units? Yes, we are. So when we repeat the experiment 3 times, we get an almost identical picture of motor unit activity. Fourthly, can we see difference between healthy subjects and patients with motor neuron disease? We don't know that yet. So where we are now is we're recruiting patients with motor neuron disease to try out this auditory paced experiment. And we're planning a longitudinal experiment where patients will come down to Newcastle 4 times every 6 months. And then we can see, firstly, whether we can detect differences between the healthy controls that we've studied, and also whether we can track changes in the activity that parallel the changes in their disease. So that's where we are. We need to see if patients with motor neuron disease can activate motor units using this auditory pacing. We need to see if the activation patterns that we see on our images are different in patients to the healthy controls. And ideally, we want to see if MRI, the imaging, changes over time with progressive motor unit loss. So we are currently recruiting, and I've already described the longitudinal study that we're planning. So finally, just to acknowledge the wider team that have done all of the work that I've showed you today. And finally, the huge thanks to MND Scotland for funding the work on the auditory pacing. Thank you very much.